Voy a empezar esta conferencia en inglés y más tarde vamos a cambiar para el español. Así que voy a utilizar unas palabras simples en inglés para que todos puedan comprender lo que estoy diciendo. My motivation for developing a gastrostomy technique was the increased number of children with inability to swallow referred for gastrostomy placement. These were very high-risk patients prone to anesthetic and post-laparotomy complications, and as you well know, there were plenty. The cover of this current problems in surgery in 1986, while I was still at Rainbow Babies and Children's Hospital, shows a review of this particular, all the gastrostomies and this technique in particular. This diagram summarizes the history of long-term gastric access in chronological order, all the way from a gastric fistula to some more complex operations developed thereafter. Most common in contemporary use are the Witzel gastrostomy right here and the Stum gastrostomy that, of course, you're all familiar with. I questioned, could an incisionless gastrostomy be accomplished in these high-risk children referred to the Children's Hospital of Philadelphia? The criteria that had to be fulfilled were control of the site of placement, protection of surrounding organs from injury, and finally, a reliable approximation of the stomach to the abdominal wall. I pondered several options like intragastric balloons, magnets, Seldinger type technique with imaging guidance, rigid endoscopy, but none of these seemed safe enough. My selected option was flexible endoscopy. Of course, this provides the approximation of the stomach to the abdominal wall by gastric insufflation, displacement of the liver and spleen out of the area of the gastroscopy, safe placement of the needle, and insertion of a guiding string or wire to the needle crossing the abdominal and gastric walls. Wire grasped by the endoscopy snare inside the stomach would then be brought out to the child's mouth. We employed a modified catheter with a tapered tip attached to the oral end of the guiding wire. This would be pulled back to the esophagus and oropharynx across gastric and abdominal walls. The passer then head lifts the anterior gastric wall against the abdominal wall, maintaining the serosal and peritoneal surfaces together. This eventually would lead to a firm adherence. This anatomical cross-section of the upper abdomen clearly shows the relation validating the safety. You can see the stomach flush with the abdominal wall. This is even more so the case in a small child, as seen in this X-ray of a crying child. Flexible endoscopy was still a relatively new tool at the time. Unfortunately, the Children's Hospital of Philadelphia, where I was a fellow at that time, did not have a flexible gastroscope in 1978. Fortunately, my future general surgical colleague in Cleveland, Dr. Jeff Ponsky, had one. The sequence is well known to you: gastric insufflation, digital pressure, and syringe confirmation. Insertion of the needle, grasping of the wire, which is then brought out to the patient's mouth. A PAG catheter is attached to the wire and guided to the mouth, oropharynx, esophagus, and finally across gastric and abdominal walls. This simple equipment that you see on the right side is something that I put together for the first percutaneous endoscopic gastrostomy, or simply PEG. And on the left side, you see the initial 1980 publication. This is one of the first patients after completed procedure back in June of 1979. You notice that we were concerned about this being pulled out accidentally, and that's why we used those sutures. Well, as it turned out, eventually this was really not necessary, and we did not use it thereafter. So now this sequence that I showed you earlier had a new way of building a gastrostomy depicted with the letter I. So what was the acceptance of the percutaneous endoscopic gastrostomy? When I first presented the PEG at the American Pediatric Surgical Society in May of 1980, along with a short movie, pediatric surgical colleagues showed curiosity and reserved interest. Almost none were doing flexible endoscopy at that time. However, when Dr. Ponsky presented the technique a month later at the American Society for Gastrointestinal Endoscopy, it caught on like wildfire. Suddenly, gastroenterologists, whose spectrum was quite limited at that time, could do a real operation. It was an enormous success, and Dr. Ponsky instituted courses at Mount Sinai, where he was working at that time, to teach the procedure to enthusiastic gastroenterologists and some surgeons. So what was the impact of this procedure? Back in 2000, I looked at how this procedure's acceptance had reached. In the United States alone, there were 279,000 procedures a year, with 4% of these being in children. Over 260,000 PEG kits were sold each year, and many nursing homes literally made it a prerequisite for the admission of patients unable to swallow. However, I was concerned because the indications were often almost casual, and overutilization had become a problem. Complications were not insignificant, and the dangers were often underestimated. Endoscopists had little or no surgical background, and follow-up was poor. Few pediatric surgeons embraced the procedure early on because they were not familiar with flexible endoscopy or simply did not have an endoscope. Eventually, calls for improved, stricter percutaneous endoscopic guidelines started to emerge. From a technical point, gradually some innovations were added, like the primary insertion of a skin level device that I developed in 1990. In 1991, laparoscopically assisted gastrostomy was introduced. It allowed the operative insertion of a balloon-type skin level device, and it is widely used, particularly by the pediatric surgeons. Several laparoscopically guided or laparoscopic techniques were described, and here's one of these done by one of my colleagues. In this procedure, sutures are added for additional safety. Here's a postoperative picture of this same child. It is interesting that the interventional radiologist also embarked on this quest to produce a gastrostomy, and here's one of the versions with CT guidance. The sequence for gastric approach modalities now had two additional options that you see with J and K, in addition to the percutaneous endoscopic gastrostomy letter I. This recent data from PubMed shows that when PEG was queried, there were 3,272 publications since 1980, an impressive number that continues to grow. If one spots gastrostomy on a graph, the numbers are truly astonishing. Interestingly, the original PEG paper in the Journal of Pediatric Surgery is the most cited publication in the most widely read journal of our specialty. In addition to our original monograph, there are now many books and other publications in multiple languages. The principle of sutureless approximation of the hollow viscus to the abdominal wall, which is basically what a PEG is, led to multiple other applications. Here are two examples. On the left, the correction of a severely leaking stem gastrostomy, and on the right side, a placement of a sigmoid irrigation tube for management of severe constipation. Long-term, let us now briefly switch to access devices. The traditional tubes were not well suited for long-term feedings, particularly in children. So not long ago, colleagues came up with a variety of ideas, as you see here, double balloons and nipples and spools, but even bulky devices like this, and also gastrostomy tubes that had a balloon on the outside. But this, of course, was problematic, as was the long tube after the insertion of the gastrostomy. For this reason, we developed the skin level device that I named button, because this word was short and non-threatening to children. Here's the cross-section of the original design that I developed with Dr. Pika. It was simple and elegant. You can see a one-way valve at the lower portion and a safety cup at the upper portion. The superiority of this device was obvious from the outset. On the left side, you see a child with a traditional gastrostomy tube and a lot of granulation tissue that we simply could not get rid of. On the other hand, once the skin level device of silicone rubber was inserted, this problem quickly disappeared. Interestingly enough, in the same 1988 issue of the Journal of Pediatric Surgery, there were two competing gastrostomy devices. This child with complex myelodysplasia and inability to swallow was the first button patient. Here he is, proudly feeding himself, and here he is visiting as a teenager. In 1995, I developed another concept, the conversion of a percutaneous endoscopic gastrostomy tube to a skin level device without removing the initially placed tube. Here's a child with a long tube, and here's the same child minutes later after the conversion. I could not conclude this talk without briefly addressing the issue of ethics. Although the indications for long-term enteral access in children are fairly clear, long-term gastric access, mostly in adults, continues to generate major ethical concerns, as illustrated by this Time magazine cover of the year 1990. So who then is an ideal patient? Well, this child was born with a very large left cervical neuroblastoma. After resection, he had difficulty swallowing, and a PEG was placed. And here you see him swallowing, being taught by his mother. the gastrostomy feelings were gradually decreased as the oral feelings were increased. And here's the same child at the age of 1 when the gastrostomy was no longer needed. Here is another example, a child with cystinosis in which the gastrostomy was used solely for the administration of a very long list of daily medications which a child could not have possibly taken by mouth. What then is the future of gastrointestinal access? Undoubtedly, advances in techniques, including additional simplification, improved, longer-lasting access devices, biomaterials allowing tissue ingrowth or incorporation of device, or even device-free access. Finally, more precise, well-defined, ethically justifiable indications for long-term enteral feeding. I will now switch the language, and we will be ready for a discussion. I do appreciate your attention.